I've met with thousands of acute and critical care nurses inspired by my AACN theme, Courage to Soar. Many have shared how the theme has helped them carve new paths, develop professionally, or even to acknowledge and face what's holding them back. On my path, I've learned firsthand the beautiful changes you can find on the other side of fear. And my guests have too. So today, I'm chatting with an amazing nurse, Jasmin Orange, who has been working tirelessly with a bedside tool to measure, predict, and mitigate workplace violence. Jasmin, we are so happy to have you here today.
Hi, Jen. I'm so happy to be here. As Jen said, I'm a nurse in a medical ICU at a level 1 trauma center, assistant nurse manager on that unit, and doing a lot for workplace violence within the organization. Luckily, had a chance to do that, and incredibly grateful to be here and share this message with you all.
Thanks, Jasmin. I would love to hear how this tool even came about. I know that you were kind of tapped on the shoulder to kind of get this started. Can you kind of talk me through that process? I think some of our newer nurses or some of our nurses that are maybe on that same type of journey in their career would love to know how you did that.
Yeah, I mean, I think it's a good story because it talks a little bit about professional governance and how that structure really helped lead me down a path into something that I'm really passionate about. So I was a member of one of our nursing workforce councils. A directive from that council was to implement a tool for workplace violence, and that was just it. It was very broad, and we're like, okay, we'll find a way to make this work.
Off you go.
So it did take partnership with nursing scientists, a lot of research about what tools were out there, what we would be able to use in our organization. We had to pivot a couple times because the tool that we initially planned to use, it didn't work out. So, there was lots of roadblocks along the way, and it did take many years, but finally we were able to implement the dynamic appraisal of situation aggression. First, we started on an inpatient unit, one unit, got feedback from that staff. We were actually able to do, part of the good thing about having to slow down and reset was we were able to automate a lot of processes. So there were a lot of tasks that nurses were having to input an order into the chart for a patient that's high risk, where we were able to automate that. So that was kind of cool. We got to make that change before we rolled out to not just all of our acute care beds at our one hospital, but throughout the whole system. So the tool is live now. We're definitely learning more since implementing that tool about other strategies that we need to have in place. And luckily, it's a very robust team. So I'm certainly not alone in any of this work. Which I'm grateful for because it's a lot. It's a huge undertaking. As we know, workplace violence is just rising. And it's going to take a multifaceted approach to really combat this.
Love that. I'd be curious how the physicians and the advanced practice providers and the other interprofessional teams have taken to it. Has anybody kind of taken and spearheaded it in those groups, or is it because this really is needing a collaborative approach that you kind of have seen them maybe organically becoming a part of them, because you really need them to be stakeholders as well?
Exactly. That's definitely been a work in progress. This is all right now nursing driven. I think one of the good things about having an objective tool is it's something that we could communicate to the providers with and say, hey, the patient, they were low risk initially, but they're escalating. Now we can objectively say that they're high risk for aggression. So it's definitely been helpful in communicating with the members of the team. We do have a group of physicians who are in clinical informatics. So I would say if anyone from a physician standpoint is really behind us and spearheading, it would be that group. They really worked on getting the tool integrated and a lot of buy-in. They've also given us suggestions about ways that we could make this the scores more front and center for the providers. So we're changing how it'll be viewed in certain areas. And we have them as members of the team. It's a big group, so we definitely have a lot of physicians and APPs that are part of the team, and as we roll out more initiatives. Initially, our addiction medicine group actually was concerned that there would be bias with those particular patients when using a tool like this, which completely understand their concern. But we were lucky in that we had our DEI team involved from the inception of this process. So we really made sure to incorporate bias training. We wanted the tool to be an objective way so that people are not just looking at different cultural things, like people who talk in loud voices. Sometimes that can come across aggressive. We really wanted to take that out of the equation. And we were able to have a sit-down discussion with our addiction medicine group and kind of come to an understanding about how the tool was developed, what the intent behind it was, to make sure that we're not marginalizing any patient population.
What I love about you including them in this is I'm sure there's other areas that as you started to learn about that EDI training and that bias training, that maybe there's other areas. You know, we have that all over medicine when we were talking about, you know, really kind of bringing health equity to the bedside and what that looks like. So I love that you guys used a multi-layer approach to really bring this information out. You know, when we talk about, you know, leading from the bedside and how do we kind of teach direct care nurses how to do that, at what point in this, I love in the beginning that you got them involved in the very beginning from shared governance, but how were the direct care nurses kind of taking to this? And did you see a sense of empowerment, and has anything come out of that?
I mean, honestly, when I started this work, I was still a bedside nurse. It's just continued as I've transitioned throughout my career. But definitely in shared governance, we've talked a lot. You know, people have shared their stories. And I think that's where a lot of these interventions that we kind of came up with, like hearing, okay, how did something not happen? And really tailoring the interventions to things that people are already doing. So we had a caregiver who shared about the experience of having a patient come back to her unit after an event. So we really wanted to make sure that whatever we put into place, like, it will keep that into consideration so people don't have to be re-traumatized. So, you know, definitely the input of staff has been crucial because we also found that a lot of the interventions that we wanted to provide were things that people were already doing. It's just like piecemeal, and all the nurses on one unit might be really good at de-escalation, but we really wanted to pull those tools in so that everyone would know the same thing and have the same information. Also, you know, create consistency for our patients. So you can't go to unit X and behave one way and then get transferred and, you know, have a different experience. They should know what our expectations are as an organization and what we hold people accountable to at every step of the process.
I'm sure there's so many other institutions that would love to have this information, and we talked a little bit about, you know, disseminating that and what would that look like, and it's not something that of course you can do alone, but have you had any thoughts about that, or what's next with this, or, you know, as this being your passion project, like, I would love to know if you see something down the road that you want this to kind of evolve into.
Well, I will say, since we last spoke, I definitely have been considering publication a lot more. I think it's just like this. Like, I didn't think that speaking at NTI was